It is 9 in the morning on the Pacific Coast, in Portland, Oregon, to be more specific. So it must be time for the NCA Coffee Club meeting. Woohoo! You guys that are members to the NeuroCentric Approach Online Academy can join us at the link over here on the Zoom. That'll be recorded and will be available on the community online. For those of you over here on Facebook Live that are unfamiliar with what all of that is, the NeuroCentric approach. It's created by Dr. Justin Dean and I. It's essentially an integrative approach for rehab, exercise, and manual therapy geeks, primarily of the chiropractic persuasion. It is as I said, integrative, using a lot of those named acronym systems that many of us have taken continuing education in. And it's my attempt to try to blend those into a more effective clinical rubric that takes into account at least three things that are a bit different out there in the literature these days from when I went through school 20 years ago. And one of those things is our improved understanding of mechanical sensitivity of neurology and how that can potentially drive motor behavior, which then will alter joint position. And then those altered joint kinematics over time can cause arthralgias. In between there, the motor behavior that changes often when we're in school, we're taught about how to palpate for tight muscles or joints that don't move so much. And what we're attempting to do with this improved understanding of mechanical sensitivity of neurology is to try to look beyond just that observation of the phenomena of tight muscles and hypomobile joints or hypermobile joints, and to try to ask a simple question: why is this occurring in this particular individual at this particular time? So part of what we're looking for is to improve our ability to query the patient in front of us as to whether or not that mechanical sensitivity is present. The other two things regarding neurology that have changed a bit since my day in school is the improved understanding of how the brain gets involved in all of this. And many of us are a bit more savvy to this these days. Blessedly, this field of pain neuroscience has matured a bit more, and now it's not necessarily seen as the be-all and end-all, but it is an important thing for all of us as clinicians to consider with our patients. So with the NeuroCentric approach, we try in our history to bring that information around into that clinical rubric as well. And the final thing that I think we're bringing to the table that is different is for some of you that are geeky and are out there listening to folks like Andrew Huberman or Peter Attia, or you're interested in the findings of the Buck Institute and looking at aging literature and longevity literature, we're seeing that there are oxidative stressors that can, beyond just the standard polyneuropathy of alcohol, diabetes, possibly drug-induced polyneuropathies, but that there are oxidative stressors, call it hard living, in a person's life that can make neurology a bit more sensitive. And it's that we're also trying to capture somewhat in the history and then factor that in to our treatment plan with that particular patient. So that is, in a nutshell, the NeuroCentric approach. The online academy I launched, I think we're at about 2 months out of the gate right now. It is the beginnings of the online coursework. I've got about 35 hours of continuing education up there right now. Current price on that is a paltry $39 a month or $3.99 a year. That price is going to go up next week, both of those prices. So if you guys have got any friends that you want to get in on that, you can do that. And also, it's worth noting, periodically, I'm going to toss the lifetime membership, which is a single payment, just one payment, and then you get our process, the NeuroCentric approach, for the rest of your life and mine, and for just one payment. And that payment also gives you a discount on our in-person courses as we spool up those in-person courses and start teaching those. So keep an eye out for that. I don't know, a standard time where that might occur is, I don't know, maybe Black Friday. So keep that in mind and maybe start talking to your peeps out there and letting them know that that opportunity is going to be presenting itself here shortly. Let's see. Things in my past week. Yesterday was my little doggie's birthday. She turned 5 yesterday, and I did something kind of fun. Many of you are aware of the chat GPT, and I've got the pro account on that, which gives me access to chat GPT 4, but also to the brand new DALL-E. And DALL-E 3 is out there, and I decided to play with that yesterday morning. You might be able to see that over there on Facebook Live just a little bit. Those of you that are here on the Zoom can see this clearly. So I put a prompt in to produce a realistic photo of a 5-year-old black tri miniature Australian Shepherd dog sitting at a table with a birthday cake with 5 candles. The dog is wearing a birthday hat. The cake has "Happy Birthday 5" written on it. And damned if the first one right out of the chute doesn't look almost exactly like our dog. It was fascinating to see this. In fact, when I first sent that picture to my wife, she said, is that 5? and that was kind of fascinating. My son, when he saw it, said, "Did you upload photos of our dog to that to get that kind of rendering?" And no, I didn't. In fact, it won't take those uploads so well, at least not at this particular point. But these are various renditions that came out. You guys, as you play with it, are going to find that it is imperfect. This is all still beta, but as you note, I had to keep prompting it. It said that was a good rendering, but please have "Happy Birthday 5" written on the cake and 5 candles on the cake. So it gave me another iteration. This cake's got 6 candles on it. This cake's got 9 candles on it. Both cakes have "Happy Birthday 5" on it. It said, now using the same prompts, produce the image and style of Renoirs at a garden party. So this was intentional because some of the artists out there, of course, are justifiably concerned about the wholesale imitation of their art style and such. And this is what Chat or DALL-E 3 gave back. It says, to create images inspired by Renoir's At a Garden Party, we would use descriptive terms such as, quote, soft, pastel-toned, and impressionistic, along with the relevant scene description. However, since Renoir's last works were created after 1923, we cannot use his specific style for the image generation. Instead, we can generate images with an impressionistic style that predates 1923, capturing the essence of that era in art. Would you like me to proceed with this approach? I said, yes. Here's what I get back. Still got the wrong number of candles. This cake's got Happy Birthday Fife on it. Now I got a little puppy Fife. She's no longer 5 years old. She looks like she's about 5 months old. And Happy Birthday something over here that's illegible. So that's kind of funny. And then I threw it, now do it in Cubist style, reminiscent of Picasso. And here are the images I got. Now in the Dutch style of Rembrandt, and we got something a little darker. So that was kind of fun. That was a play toy yesterday morning for my doggie's birthday. Welcome in, Guillermo, and nice to see you, Kat, over there. Kat, have you had any new information about your possible trip up here to the Pacific Northwest? Hey, Guillermo. Good morning,
Hey,
brother.
Phil. How are you?
I'm well. How about yourself, bro?
Pretty well. Yeah, it's definitely wet and windy out here, isn't it?
It is indeed. It is completely sopping wet outside. I don't think I'm going to be able to get to the dog park probably until 1 or 2 today if it opens up. But it's going to be an indoor workout day today.
Yeah, for sure.
Yeah. Let's see. Let's do a recap as we move into our case of the week. Let's do first an old business. Last week we talked about a 58-year-old female with complaint of lateral hip pain with radiation into the knee with Orange Theory workouts. Her past health history was of note because she had past health history was interesting of note because she had concomitant prior history of melanoma twice, and she has a diagnosis of osteoporosis. And subsequently, as we get that phone call coming in off of there. Subsequently, as I did some work on her, we determined that she had femoral nerve sensitivity and across multiple peripheral nerve areas in her thigh. We trialed some MDT interventions to see if we could take that off, some heat off of that neural pathway upstream. MDT didn't do so well. So we tried NDS, Michael Shacklock's work, and started with static openers. Some might ask why I would do that, and indeed, why would I order it that way? Because some people that have taken Shacklock's work, some people that would have taken Shacklock's work would start right there. Someone is definitely trying to get into my meeting this morning. Hang on a second, please. It's not because of effectiveness that I opt for starting typically with MDT. Part of it might be a bias because I was exposed to that earlier. But I think the primary reason that I do that is because MDT interventions typically are easier for um, for our patients to intervene with, and I'm more interested in that. I want their compliance with homework, so I tend to use MDT. And in her case, the static openers, they involve the need for something that she can lay on. And, luckily she works from home. So she can go to her bedroom and she can get up on her bed and do the static openers. But what happened over the course of a week, when she came in to see me, she had 6 weeks of near constant pain in that left lateral leg. And after 1 week of doing static openers, um, between 3 and 5 times daily, she had zero pain. It was 100% resolved, and she was able to continue her workouts without any aggravation based on the improved understanding of the mechanics that were likely picking the scab, if you will, on that condition. So there's old business from last week's issue. Does anybody have any questions about that before we get on with the next case? Not seeing any questions over here on Facebook or over here in chat. So without further ado, I had an interesting case this week. As many of you are going to note, as you get more involved in this NeuroCentric approach, it tends to make people talk a little bit about you, because often you're behaving in a way that's a bit different than what people are used to. And you're likely to find, as I and others that have adopted this methodology, that your outcomes improve quite a bit. So as that happens in your community, you're going to start, perhaps even unfortunately, some of your softball cases are going to start falling away because your schedule is going to be occupied by challenging cases. As you get more noted for this kind of stuff, you will find that you'll get more and more complicated cases. Sorry for that, but you're going to be able to help people across a broader spectrum than possibly you previously were. I think this patient might be one of those. I don't know yet. This particular patient is a 48-year-old male, a Marine on 50% disability. He moved to Portland just a little bit ago and is working at a construction firm that some of my other patients own. And they sent him in because of the symptoms that he was presenting on the job, that they thought were worthy of him coming in and getting assessed by me. So he's been seen by VA docs for 15 years after he had, while in reserves, a motorcycle accident. And in his motorcycle accident, he had a 3-level lumbar spine fracture, L3, L4, and L5. Lumbar vertebral bodies were fractured, not severely, but apparently, and I'm saying apparently because he's not yet produced the actual reports or images to me, so I had to fly blind. I said, hey, yeah, I told him, I said, hey, you're asking me to do mechanics here with the hood down on the car. So, we'll do the best we can, but a lot of this is going to be me guessing about things. And prefer to guess less with some of your information. So all of that's pending. We'll follow up on this particular case, hopefully next week as well. Presenting symptoms. The one that, of course, stuck out the most to me was he has about 7 times a year an incontinence episode associated with movement. And the incontinence is bowel and bladder. Daily, he has pain into the base of his penis and pain into his scrotum. He has very reliable movements that he can do that will reproduce that pain. So we've got cauda equina syndrome symptoms right out of the gate, but they're intermittent, and they've been investigated by other docs previously, and surgery has been offered to him to stabilize the segments in the lumbar spine that were injured in that motorcycle crash, and the patient's reticent to get the surgery. Candidly, it sounds to me like that probably would be a decent idea as well. But he presents to me with a desire to try to avoid surgery and improve his symptoms. So I'm going to try to meet him where he is. And I told him that I would do my level best to see if we could find a happy meeting place there and improve his symptoms somewhat. Most of you that are familiar with our work know that the nature of the exam that we do, and that many of us do, is provocative by nature to try to bring the pain symptoms up a bit so that we can both see them, the patient and I. And typically that infers some things that the patient might be doing that are inadvertently provoking their symptoms, and would also infer some things that we might be able to do to reduce their symptoms. And using a systems-based approach, we perturb the system, we apply an intervention, and we look for an output on the back end of that to see if the patient is feeling better. Since part of our output on perturbations in this particular individual system is incontinence, and neither of us wants that to occur in the clinical encounter, we had a discussion about that right out of the gate, that if I was coaching him into anything that he'd already identified as potentially provocative there, to let me know. So regarding the incontinence, we laid some ground rules out on that in our physical exam. And then we tried to establish some ground rules around pain. Per his history, all pain, all movement is painful. Every single movement that he does, he feels pain. He feels a constant baseline level of pain at about a 3, and his pain increases to about a 5 with any movement. Leaning into the incontinence symptomology, I asked him if he could reliably reproduce those symptoms, and he said not reliably, but the most consistent provocation he had was if he was on a job site, and he does most of the bidding for their construction projects. So he goes out and, you know, he's crawling around in attics and you know, interesting places. And he said most reliably, if he steps forward and then has to reach his leg around something, then he has to immediately stop and really kind of tighten things down, or he feels like he's vulnerable in that moment to possibly having some slippage of both bowel and bladder. So I watched him as he described this while he was standing, and I noted his movements. He showed me an extension and a reach with his leg. So in my mind, thinking into the area of interest at the spinal cord and the nerve root and the IVF, I'm seeing extension, and I'm seeing psoas activity happening at the same time. So I kind of catalog that in my mind and roll with that. As I coach him through the cardinal planes of movement. In his case, I say, are you able to do these particular movements? And what do you think the symptoms might be if you did them? And we made informed decisions about whether or not we were going to do those movements based on his presenting symptomology. In his case, he said he can get to the floor close to his toes as long as he does it slowly and carefully. So he showed me that. And he didn't have much in the way of increase in symptoms, in contrast to what he said, that all movement would hurt. But as soon as he started any movement backwards, it was no bueno. He was moving into, he's like, that is very reliably going to make a lot more pain. And it might even make my incontinence symptoms come on. So that I thought was kind of interesting. I flagged that because in that department, I start to look at an instability pattern as being the provocation, and spondylolisthesis comes up relatively high on my list in that query. We did a neuro exam. He already had admitted to sensory diminishment on bilateral lateral thighs, and he also had some diminished sensation in his history and saddle paresthesia distribution. His reflexes at the patella and the Achilles were hyperreflexive. And then on our motor exam, which you guys know I prefer to do as a more objective, patient-performed examination of S1 with repetitive toe stands on single leg, and then L5 myotome with repetitive heel stands on one leg, and then L4 and above myotome by having a single leg sit to stand. As we started to do the S1 on the right-hand side, he noted that, one, he had more pain, which is not uncommon, but he noted that it felt weaker, and he noted that it felt weaker in a particular way. He said he felt like it was ratcheting. That was his words. And you guys know that when we think of ratcheting in a neurological condition, it pushes us right upstream to the spinal cord. And we start to think about something that looks like cauda equina syndrome or something that looks like myelopathy. And in his particular case, now adding that to what appears in my emerging narrative to be an instability at the lumbar spine at an unknown number of levels, seems to be contributing to some spinal cord involvement. I decided to, in the moment, see if we could explore that IVF and see if that is somehow implicated. So I had him, he was doing the S1 on one leg, on his right leg, doing toe stand. So I had him alter his position of his lumbar spine while he's doing it. So he was upright while he was doing it and reporting ratcheting. So I put him in a position of forward antalgia and a little bit of leaning away from the affected side to ostensibly open the cross-sectional area of the neuroforamen of the nerve root that we were testing. And as he did that, he said, that feels stronger and I'm no longer ratcheting. So that was kind of interesting. And then when he was fine on L5 myotome on that side. When we did L5 myotome on the other side, he had a similar ratcheting and weakness complaint on the left side. So I did the same thing there and moved him into a forward antalgia and a slight lean away. And once again, opening the neural foramen on that side. His strength in the L5 myotome appeared on that side. So now I got a rock and a hard place, right? It looks like I've got one nerve root that is responding to an opening procedure and the other in one direction, and the other nerve root below it or above it behaving in a similar way with the opposite movements. I'm like, this is going to be a challenging one. So I decided in the moment to see, okay, if we've got an instability pattern and we have a change in his stabilization strategy, are we able to have a change in his symptoms? So I thought off the cuff about possible ways that we might be able to change stabilization strategies with these. And I felt like it would be a little bit ahead of the curve to try this with his motor testing. So I decided to try using his leaning into his provocative reach with his leg. So I'm thinking psoas activation, potentially anatomically unstable segment, and the psoas activation is pulling the spine into an anterior position. So if we've got an anaerolisthesis, we could be worsening that. So in standing, I had him just do a very careful knee raise, single leg knee raise. And he had worse pain raising the knee on both sides, no provocation of his incontinence, subjective incontinence feeling. And at that point, I sort of called a stabilization audible. And my stabilization audible is almost always going to lean towards DNS. So in that rubric, we've got the desire to create a low threshold stabilization strategy, a more efficient stabilization strategy at the lumbar spine using deep spinal stabilizers like the diaphragm, the pelvic floor, the internal and external oblique, the transversus abdominis, and the multifidi. And we're going to not preferentially try to recruit something like the transversus abdominis using Hodges' earlier material. We're going to use more of a robust McGill and DNS hybridized sort of blending of all of that, but mostly leaning on DNS principles there. So I sat him down and I sat behind him and I did a intra-abdominal pressure and IAP assessment per DNS, the way that I was taught. And the way that I do that with my patients is I put my hands on their flank with 4 contacts, 2 in the front, 2 in the back, and I have my patients to put their hands just over the top of mine. And then I bring their attention to that area and ask them to breathe diaphragmatically. And then we both see if they're able to expand in that area. So I give them a rep or 2 of breath to see how they do. And then depending on how they do, I'll work on coaching cues there. So I'll say, I'll put my hand in front of them as I'm sitting behind them, and I'll say, your diaphragm is cup-shaped. And as you breathe in, you make the muscle tight. And as it tightens, it pushes down. And as such, it should expand that cylinder, that canister that we both have our hands on here. And we're looking then to get a sense of that expansion. And then I give them another few reps to see if they could work on that. So in this particular patient, he was breathing paradoxically. As he inhaled, his abdominal canister would contract and everything went north. All of his breathing went up here. Other interesting things in this person's life, he's going through a divorce. There's custody battles for the kids. He's living in a new city. He's got a new job. He's trying to negotiate all of these new things. So he's got a fair bit on his plate. So in his, he actually was, his interoception was sufficient enough that he could feel that he was breathing in the wrong area. So that's where I break out my next coaching cue, which I like for diaphragmatic breathing. I said, all right, I want you to imagine as you sit here that your torso is a big giant water pitcher. And I tap the top of his head and I say, this is where the top is. And I tap the bench and I say, this is where the bottom is. And then I ask him a question. Now, if I pour water into the top of that pitcher, where does it land first? And he says, in the bottom. I said, okay, now I want you to imagine that the air that you're breathing in is heavy like water and that it flows in through the top of the pitcher. And I want you to fill the bottom of the pitcher first and only fill up to where our hands are. Okay, so he doesn't even get a chance to come up here into the chest. And he did a few reps there, and he demonstrated that he was able to produce a diaphragmatic breath. So now, this is part of what we do, or what the Kabuki system of their progressive loading processes incorporate, how they incorporate the DNS material. So first, we want to try to see if that individual can volitionally breathe into all four of those quadrants. Now, in our athletes, what we will commonly find when they are injured is that they are off in one of those quadrants. And when you palpate those and you have them try to breathe into it, commonly one of those quadrants is not getting expansion. And commonly that's, if they have back pain, that's the quadrant, that's where they feel their back pain. And for those of you thinking about possible DTM contributors there, often you can lay them on the side in that back pain and do deep palpation through that abdominal wall, and you'll probably localize a small nerve, ilioinguinal, iliohypogastric, sometimes subcostal, in that abdominal wall. And they'll note that it's really painful, and you can do some my DTM in that particular area involves using transverse nerve mobilization, bending that nerve laterally while the patient twists on the plinth or the table. If you want to see that, those of you that are members, that's in the cluneal neuralgia and groin pain course that's there, that how to videos in there on that. So in this particular patient's case, we were able to volitionally breathe in all four quadrants, and now we want to see if he can brace in all four quadrants. And we think about the brace as being on a rheostat, a dimmer switch. We don't want the patient to walk out of here with the same kind of attitude that many, Stu McGill got bashed on this in social media for years for making patients hypervigilant about the need to brace. And all of this talking about bracing left a lot of people walking around with a real hard brace all the time. And for those patients, I always say, no, that's not the goal, because that'll just make you walk funny and make dogs bark at you. So we want only the amount of brace that's necessary for the desired goal. And just reaching out for a coffee cup is going to be just a little bit of bracing there. So we practice just a little bit of brace, and I wanted him to imagine a 10% brace as we put our hands on there, and I'd have him close his glottis, and I make the sound. Some of your patients, when they try that, do what? They go, It's not boom. And we want boom. We want control. We want control of that intra-abdominal pressure very quickly. Why? McGill gave us a paper a number of years ago on investigating Bruce Lee's double pulse idea, of the idea that when you generate a quick movement, you have to first be stiff, and then ironically, you have to be very loose to allow the movement to occur. And then you have to be stiff again when you have the contact with the limb in order to achieve an energy transfer into the target, whether it's a kick or a punch or strike of some sort. So McGill showed in that paper that, which was done at George St. Pierre's training facility up near Toronto, that all of the athletes in that environment were able to very quickly muster that intra-abdominal pressure on EMG testing. But the best athletes in their facility were the ones that could turn it off quicker. So there you think cat-like in that ability to be completely relaxed and then boom, just to explode and then to chill again. So that's the kind of message as we start to play with this stabilization that we want to impart to the patient. And the DNS principles, these low threshold stabilization, ironically, only requires a little bit of stabilization. So I've found, and I've got one MD right now, an urgent care doc, that we've been working through prior disc herniation, that now most of his pain is cluneal neuralgia. And the most valuable thing to help him with that pain was to teach him to breathe into that area and to stop trying to muscle up to protect his back. So he has been walking around for years with a body awareness that if he rounds his lower back, his disc is vulnerable, and he has inculcated a posture into his body of muscling up all the time. So he's walking around with a proud chest. And the most effective visit we had was when I gave him permission to just let his back go. And that sounds a lot like some of Peter O'Sullivan's, work, and how he would get all uppity and talk about, those patients that we get like this, that, and he would bitch about Stu McGill's, causing more harm than good. And that's crap. We get some patients that are in this bowl, and we get other patients that are in the other bowl, that if they flex their spine, they've got a more acute injury, or other things are involved, and they're a very flexion intolerant pattern. So it all depends on the patient that's in front of you, which brings us back to our case study and the patient that's in front of us. So his interoception was very good. Clearly, he had some athletic training. He's a Marine. I expect him to be, at least at some point in his life, to be physically proficient. And he was able to brace effectively in 4 quadrants. So we went back to our standing single leg knee raise or hip flexion, which previously had caused pain. And first I coached him into a little bit of bracing in that area, and then had him to flex the hip. And when he did, he reported that it was well over 50% less pain. So we worked on dialing that brace a little more. And as he upped the rheostat on the bracing, using that bracing strategy, he was able to raise his leg with no pain. Very cool. Okay, so in this particular circumstance now, we've got a person. I mean, let's be honest. If you had the possible symptoms that you're going to piss yourself or shit yourself on a job when you move in a certain way, do you think that would involve your nut at all? Do you think your head is going to be involved in that? Do you think that's going to make you feel less secure, worried at your job site? The fact that this guy is carrying a backpack, and I already know what's in his backpack. It's a change of clothes and possibly a Depends. And this guy's 48. So I'm going to be happy in this first encounter if I can take away some of the presenting threat that's making him feel less secure on the job at a place where right now, with a change of venue, a change of scenery, kid issues, relationship issues with the divorce, he needs to feel some sense of control there. So we start to blow that up a wee bit, and let's talk about, okay, the other positions. I said, okay, so now we've identified that reaching position with your leg, likely involving the psoas pulling on the spine. I showed him the anatomy and suggested that if he provides that little brace, if he anticipates and sees that situation, one, if he can identify a better way or a way that's less threatening to move rather than exposing himself to that, then by all means do it. But he's probably already doing that. But the second thing is to, if he has to do something like that, to practice this bracing strategy when he does. The other movement that we identified that was provocative for the back pain was extension. So we worked on that rib down position to try to keep that a little bit more, and then work on using a squat mechanic to get lower rather than an extension to try to avoid that, that particular provocation. And candidly, that's where we left it on this particular event. This was a complicated enough case that I wasn't going to do a slump test on it. I wasn't going to do a seated compression test on it. I wasn't going to do an SLR. Based on the physical findings on the neuro and the historical data collected, I'm working a narrative that suggests that I've got an instability pattern that is presenting threat to the spinal cord and the nerve roots. And I'm going to see if we can institute an improved stabilization strategy using DNS principles and try to improve his function at work. We'll see how that goes and do a conservative trial for a number of visits, and then consider whether or not this is most likely a surgical intervention to stabilize that particular area. And if it is, then we'll follow up with that with rehab to bring it back up to a high level of function. So that is our case study for this week. Questions? Anybody over here on Zoom? Thoughts? Anybody over here on Facebook Live?
Gotta say, that is one difficult case.
Yeah, it was, Guillermo.
And I think what you were saying about your concern, because there's got to be a mental component to it for sure, in addition to, you know, the stability issues.
Yeah, absolutely. The you know, I think back about two events early on, and in the first couple of years of my practice, I remember at that particular point in time, I was working 2 rooms and working back and forth from room to room. And, like many of us that do that kind of work, it's always a challenge to put to encapsulate or to I don't know what the word I'm looking for is, to try to take what happened in the last room and categorize it, stick it away, and not trail it in to the next patient encounter. Trail it in like a piece of toilet paper on your shoe walking out of the bathroom. So I would always stop in front of the door as I've got the patient's chart in my hand and flipping them open in the old days of paper charts. And I'd take a deep breath, stop there in front of the door, and I'd close my eyes. And then one day, the words, show me where the greatest threat is, popped into my head. And I'm like, wow, that kind of is what we're doing, isn't it? Where is the greatest threat? And that is where I want to try to double down and get my first lever under. And in this particular individual, I could only imagine that the security issues are bound to be very high up in his world. The toilet paper idea, Guillermo, comes to mind. Oh my, and Dave Panzer just dropped in over here on Facebook Live. Dave, hello. It's so good to see you in there. So when we were doing OSCEs, Guillermo, I was a bit of an older student going through that. And I remember as we were there in our nice starched white jackets, in our little groups of 3, standing at the treatment room door, and we hadn't yet started our vignettes. And we had just a moment, and I could just feel the tension, and again, I was an older student, so I felt kind of like a father figure at that time to some of these kids. And I was like, well, how do we diffuse this with a little humor? So I asked, hey, if I got time to hit the loo right quick. So I went into the bathroom and I grabbed a piece of toilet paper, ran off about a 15-foot long piece of toilet paper, and I tucked one end in the back of my shoe. And as I walked out of the door, I dropped it. And then I just trailed this piece of toilet paper in my shoe all the way down the hall until the whole hallway, everybody was just cackling. I'm like, okay, guys, it's not all that serious. We can get through this. But the other story I mentioned that had come to mind that I'm thinking about, remember how we were just discussing how I was doing a motor exam with a single leg heel and toe stands. And then in this particular patient who was presenting with a ratcheting type of motor behavior, theorizing that we've got some instability and a spinal cord presentation of sorts there as a result of that, I was trying to move him into a position with his body of forward and lateral antalgia to maximally open the surface area of the putatively evolved neural foramen. And that part of why I have thought that along those lines is in the very first year of practice, I remember getting an MBA patient that came in, and in my workup of this particular patient, they had been in a really severe accident. As I'm doing DTRs, they were hyperreflexive in their biceps and on one side. So I tapped the bicep, and then on the fly, I just thought, wow, I wonder what that would look like if we altered the IVF. And as I was doing the biceps DTR, I said, do me a favor, tilt your head back. And he tilted his head back. And as he did, the hyperreflexia stopped and it became normal. And then I said, okay, now bring your head back to neutral, and continued this, and the hyperreflexia came back. And doing that, as this is an output, this is an input with head position, we just started to explore ranges of motion or head positions to offset or to reduce putative threat presentation at that particular level. And then basically showed him that with clear inputs and outputs, that if he is feeling sensitive or symptoms, that this might be a rescue posture for him. And it seemed to help in the moment. In fact, I think I told Dave Peterson about that, Dave, and Dave said in his typical way, sounds like that'd be a good case study. Yeah, you ought to write that up.
Phil, with this patient, does he have ED, erectile dysfunction?
Yes,
okay.
He does.
Now, you had the provocative tests. Most of them were stenting, if I recall. Did you try to do any of those with him just laying on the table on his back and see if he can reproduce?
I didn't. Probably the only reason at that point was one time, because as you've noted, this is a complicated case, and there's a lot of history in this because we didn't want to have an incontinence event right there in the room for either one of us. And for him, with the instability issues and such, just the changes in posture were enough to make me concerned about what we were going to be having happen there. So I punted on that one. That will be the first thing that I explore in all likelihood when I see him this week, because that I'm going to lean into those DNS 3.5 month supine position exercises, and I'm going to see how well he manages that. And I'm going to coach him into what he's already learned with just abdominal bracing and in the transitional movements to get to different places. And first we'll check his issues with the reach, the hip flexion and the reach, which were potentially provocative as well.
Yeah, the reason why I asked you that question is that's something I like to do, is one, take out gravity. But once they're lying on the table and you can provoke the pain, like in his case, hip flexion, and I'm suspecting some kind of instability, if I position the patient right before he feels discomfort and I have him bring his hands up, I give my back to them and I have them push against my back, that causes the bracing. If the pain improves, and a lot of times it does or it goes away, then that's another confirmation, and it makes it easier to be able to coach the patient in abdominal bracing.
I like that, Guillermo. That's really tight and very tidy and concise, and you don't have to talk about it a whole lot. You can just have them do it. I like that. That's a really good kinesthetic cue. It's reminiscent of some of the stuff that Andrea Spina does with his FRC kind of stuff. I've got an exercise that Kat, you would appreciate this, because I think you've done some of Spina's work, if memory serves. But I do one called Claim This Land, and I'll take a staff or something like that, and I'll have them stick it in the floor, and I say, this is your flag, plant your flag, own this ground, and really shove it down into the ground. And that'll be part of what we work with this patient again next week, that shoving that down into ground and that providing anterior oblique kinetic chain closure, force closure across the front of the pelvis should theoretically improve their lumbar stabilization capability. And then when they ask the psoas to take moment on the hip by virtue of stabilization at the spine, we should have less symptoms, and that would be a way to scale that exercise plan as well. And then we could take one out of FMS, SFMA. They've got some lovely supine progressions as well of using a cable stack apparatus overhead and getting legs up in a supine 3.5 month per DNS position and doing cable rows over the top to work on that closure across the front. And I would add to that one not only bilateral but also unilateral, and working individual pulls on that too. Just some thoughts. Well, this was fun. We'll see hopefully next week if this patient is responding to the cueing and such, or if they are indeed a surgical case. I think we're going to give it, based on, I think he's got 15 years of chronicity here with this intermittent kind of presentation of incontinence. I think we'll probably give it a few visits at least before I weigh in with an opinion on that. But that is the bit for today. I usually would want to end right at 10, but I've got to see if I'm able to bring Dave in here. Uh-oh. No. So I'm not seeing that Dave has got that activated. Let's see.
I gotta say, Phil, I get my share of complicated cases, but I'm certainly glad that I didn't get this one, and I hope I never do.
It's
I'm a little traumatized right now, man. I hope I never get that.
You'll be all right. You'll be all right, Guillermo. Give yourself a hug, man. At this stage, I guess the blessed part of where I am practice-wise and all is I've got enough room in my day clinically. I put a fair bit of time in between patients. I don't have to be, like jamming patients through and such. So I can do relatively, I can take a case like this and spend a bit more time if necessary. And quite honestly, it is, I find it perversely engaging, because it's like, all right, a puzzle. I do Wordle every morning. I like doing puzzles, and these complicated cases, I'm humble enough to know that I might not have an answer, but I'm also real enough to know that a lot of these patients, they don't have any options.
Right.
And I'm also aware that this heuristic that we're playing here with this neurocentric approach is different enough that it's, in all likelihood, it's stuff that hasn't been applied in this particular patient's case before. So we'll at least give it the college try and see how things go, and then be very honest with the patient. I don't know if we're going to be able to make you better. I have no idea, but I'm willing to try, and we'll give it a shot and not set unrealistic expectations in the patient. I'm bringing, let's see if Kat wants to come on. Kat, are you dressed appropriately? All right. Looks like everybody's shy this morning. All right. Well, that's cool. To everybody that came in this morning, thanks over here on Zoom. Thanks over here on Facebook Live. This will go up on Facebook Live for 30 days. You can watch the whole thing. Over here on Zoom, I'm going to take the transcript and the recording there. Did you see that one last week, Guillermo? I've got a recorder on here from Rewatch. So you can see the video and then at the same time have the transcript handy. And what I'm doing is taking all of that and putting it up on my YouTube channel as well so that anybody can see that. The idea here being to get the word out about this process that we're working so that others can understand it. As I said before, we will probably hold or drop another lifetime membership deal on Black Friday. So if you've got colleagues, other students in your world, CAT, folks at R2P and such, send out a message to them and let them know to keep their eyes peeled and start showing up on these. CAT, if you want to just shout out to the R2P folks at the different schools and such, and maybe get in touch with Corey Bailey, and let them know. So I would love to see some of the R2P students showing up in this environment and just getting some exposure to this to prick their knowledge, not to make them pricks as as students, as Dave can appreciate. If you get students too far afield in some of the other stuff, the course curricula is already busy enough to occupy enough of the cranial real estate there, that if we get students too far afield doing other interesting, perhaps very useful, but distracting kinds of things, and they start to think, oh, my education is no good. But I think the first order of business is to take is to value the opportunity that is placed on you guys as students when you're in the program to learn from your professors and to learn to be effective doctors, so that you can wade into that case as a responsible provider of neuromusculoskeletal interventions, as a respected member of the care team with our medical counterparts and so forth. So do that first, and then we add this kind of stuff that we're doing, which is an integrative rehab approach onto the top of that as a way to keep you organized and not getting lost in the weeds with your clinical encounters when they get a bit complicated like this one that we covered today. Big hugs to all of you. Stay dry out there today if you're in the Pacific Northwest. And I will see you guys next week at 9 a.m. Pacific time for a cup of coffee. Be well. Take care of people. Do good work.
Take care, Phil.
Thanks, Guillermo. Be well, brother.